Antibody-drug conjugate are going to completely replace standard chemotherapy across the subgroup of several cancers. In the first-line setting in HER2-positive disease, we have actually the combination of trastuzumab deruxtecan plus pertuzumab that clearly demonstrated the superiority to chemotherapy plus dual blockade pertuzumab and trastuzumab. In the DESTINY-Breast11, we have an overall median progression-free survival of 40.9 months versus only 20 months in the standard of care, that is chemotherapy plus dual blockade. In triple-negative disease, the combination of sacituzumab govitecan plus chemotherapy is superior to chemotherapy plus immunocheckpoint inhibitors. So also in the triple-negative disease, an ADC is going to replace standard of care. And finally, in HR-positive HER2-negative disease, the use of trastuzumab deruxtecan in HER2-low and HER2 ultra-low disease completely replaced chemotherapy. So how ADC are impacting in the life of our patients? First, reducing the exposure to chemotherapy. Second, giving an opportunity of treatment that is more targeted, designed specifically according to the presence of a target antigen. Third, we are going to move all these ADC in the early breast cancer setting. At ESMO this year, we are going to listen to the DESTINY-11 data. The DESTINY-11 explored the activity of trastuzumab deruxtecan plus pertuzumab, followed by chemotherapy with respect to the standard of care. And we know already that this combination was better than chemotherapy and anti-HER2 blockade in terms of achieving a better pathological complete response. ADC are part of our standard of care, and if you imagine in the last 3 years, we completely changed the clinical practice guidelines. These are a class of agent with higher therapeutic index, and these impact in terms of response rate, of median progression-free survival, and mainly also overall survival. This is an excellent question. You know, once you deliver an ADC in the first line, it can be conjugated with a topo-1 inhibitor or with a microtubule inhibitor. Usually the activity of the second ADC, let's say ADC2, is less in terms of median progression-free survival. So we hypothesize several mechanisms of resistance. The first one can be related to the cross-resistance of anti-topo-1. You know, eruxtecan together with the govitecan, they have a similar mechanism of action because they are topo-1 inhibitors. So if you had an exposure to ADC1 and then you have an exposure to ADC2, the mechanism of cross-resistance of the two payload can explain the less activity of the secondary ADC. But we know from translational research that other mechanisms of resistance can be explained. The first one can be the downregulation of the expression of the target antigen in the DAISY trial, for example. After exposure to trastuzumab deruxtecan, it has been described that in those patients who progressed, we have a downregulation of their HER2 expression. In the ASCENT trial, has been done a beautiful study with multiple biopsy of patients progressing to sacituzumab govitecan, and it has been described by NGS in the context of the clonal evolution that patients resistant to sacituzumab govitecan can have a mutation or on their receptor of TROP2, specifically the TAXDT1, that is the gene encoding for TROP2 receptor, finally have a specific mutation that will reduce the capability of sacituzumab govitecan to target the target antigen. And also another mutation was described on TOP1, that is the gene encoding for the enzyme metabolizing topo-1 inhibitors. So future research, of course, should explore first the sequence of ADC and second, eventually some biomarker that can predict the resistance to specific ADC. I believe the best combination should be an ADC plus immunocheckpoint inhibitors. If we check the data of the Begonia trial, that was a trial exploring the combination of datopotamab deruxtecan and durvalumab, is almost clear that in triple-negative disease, also in the front line, independently of an expression of PD-L1, once you expose to datopotamab, you increase immunogenic cell death, and then if you boost with the immunocheckpoint inhibitors, you can achieve response rate close to 80%. So there is a clear synergistic effect between an ADC and immunotherapy, and this was demonstrated also in the triple-negative study with sacituzumab govitecan and pembrolizumab compared to chemotherapy and pembrolizumab. In that trial, the median progression-free survival improved from 7 months to 1 year, and response rate was higher. So this is a typical example of synergistic effect. Another synergistic effect is with other antibody, trastuzumab deruxtecan plus pertuzumab in the DESTINY-9 trial can increase the rate of response up to 85% and can improve the median progression-free survival up to 40 months. So it's important to understand that ADC can be combined with other agents because our antibody drug conjugated is something like a smart chemotherapy, and if you combine, you can enhance their activity. You know, ADCs are a platform that is expandable indefinitely because finally, once you identify a target antigen, you can build an antibody and you can conjugate, of course, a chemotherapeutic agent. So the first point is that you can conjugate several types of chemotherapy. The second point is that you can generate several types of antibodies. If you explore the treatment landscape in bladder cancer, in lung cancer, in rare disease, it's almost clear that antibody-drug conjugated are the future of cancer treatment. They are going to replace completely chemotherapy in many of the diseases that we are currently treating. And in some diseases where the impact of chemotherapy is very limited, think about bladder cancer, ADC gave a huge impact in terms of median progression-free survival and overall survival. The most important question for the future will be how to manage toxicity. Because you know, the spectrum of ADC is very large, but also the spectrum of toxicities is very large. And sometimes similar target antigen ADC with a similar payload give a spectrum of different toxicities. So the study to do for the future is to test effectiveness in the real world and to better understand not only how to manage, but how to prevent toxicities.